So as we all know, that contrast-induced AKI is a predictor of poor prognosis over the years, and that ACS increases this risk threefold. So due to the increasing incidence of diabetes mellitus, chronic kidney disease, and coronary artery disease, this is an important population to address. Over the years, few pioneering studies have been done by Keshav Naik et al. And Ziad Ali et al. In the field of ultra-low contrast PCI and zero contrast PCI, guided by the Mozart trial, which showed that use of IVUS in imaging drastically reduced the contrast dose in the PCI. A retrospective study was done by Azeline et al. In 2020, in which he took 8 patients of ultra-low contrast PCI and compared them to 100 patients of conventional PCI and showed drastic reduction in the incidence of contrast-induced AKI. So we designed this study as a prospective, randomized, open-label, single-center study to find and compare the incidence of contrast-induced AKI in an ultra-low contrast PCI versus a conventional PCI, and also to assess short-term safety outcomes of an ultra-low contrast PCI. So the sample size was based on the proportion of contrast-induced AKI in a similar study population in previous study, and came out to be 82 patients. So the patients were assessed for eligibility, and the inclusion were that patients were needing PCI for an ACS with a reduced GFR of less than 60 ml and moderate to high pre-procedural risk for contrast-induced AKI, which was calculated in all the patients by a pre-procedural risk score. So these patients were then randomized using symbol random allocation using draw of lots into 2 groups, and 41 patients were allotted to ultra-low contrast PCI group and 41 were in the conventional PCI group. So the conventional PCI was defined as the ratio of contrast volume used in the procedure to patient's GFR of less than 3:1, and ultra-low contrast PCI was defined as a contrast volume by GFR ratio of 1:1. Contrast-induced AKI, AKD and CKD were defined as per KDO guidelines. The pre-procedural assessment was done in all the patients. All patients were hydrated, blood samples were obtained, and patients were followed up for 30 days for outcomes. So in ultra-low contrast PCI, we used techniques previously pioneered by Keshav et al. And Ziad Ali et al., including hooking with normal saline, then using landmarks or metallic saluting, marking wire technique, and use of stent enhancement technologies and use of imaging. So the primary endpoint of the study was defined as the development of contrast-induced AKI, and secondary outcomes were any need for dialysis, rehospitalization for any cause, death from any cause, repeat MI, or any unplanned coronary reinterventions during the 30-day follow-up. The statistical analysis was done using IBM's SPSS statistics version 22. So in outcomes, the average mean age of the patient was 60 years, 80.5% patients were diabetic, 78% patients were hypertensive, and 7.3% patients were in hypotension. The estimated GFR of the group was 42 mean. Acute kidney disease was diagnosed in 36% patients. CKD was diagnosed in 63% patients. And the risk stratification of the patients was done using the pre-procedural risk score. So 39% patients were treated for a single vessel disease, 43% were treated for a double vessel disease, and 18% were treated for a triple vessel disease. The most common target vessel being left anterior descending artery. 27% patients had complexity of B2, and type C lesion treatment was in 43% patients. So the average number of stents placed per patient was 1.59, and all these were statistically non-different in both the groups. And however, contrast volume used, which was expected, was significantly less in the ultra-low contrast PCI group versus the conventional PCI group. And the contrast volume by GFR ratio was 0.976 in the ultra-low contrast group and 2.68 in the conventional PCI group. So we saw that there was a significantly more primary outcome of contrast-induced AKI in the conventional PCI group at 17.1%. And also, we followed the patients for the GFR throughout the study follow-up, and we saw that although the GFR as a whole of all the patients rose from the pre-procedural GFR estimation to the 30-day follow-up, however, there was a certain dip in the GFR on day 3 in the conventional PCI group compared to the ultra-low contrast PCI group. There was no significant difference in the secondary safety outcomes. So over the years, very few studies have explored the ultra low contrast PCI. The pioneering study was done by Naik et al. And Ziad Ali et al. And we performed the study comparing these patients and was the first randomized and prospective study. So limitations were single center study and primary PCI and CTO were excluded and limited follow-up of 30 days. So in conclusion, patients undergoing conventional PCI had significantly more incidence of contrasted AKI in the patients. In ACS patients with baseline renal dysfunction, PCI was associated with improved GFR and should not be hesitated or denied to this high-risk group. And ultra low contrast PCI was safe and effective and applicable without lesion restriction. Thank you.